We're going to Hi, everyone. Welcome. We'll be getting started momentarily. We're just letting some more folks enter into our meeting. And good afternoon, greetings, wherever you are logging in from.
Good afternoon.
Good afternoon.
Good afternoon, everyone.
Good afternoon.
Okay. All right. Well, amazing. Welcome, everyone. And we're just letting a couple more folks in. But greetings, everyone. Thank you so much for joining us today for our webinar, Long-Acting Injectable PrEP is Here, Implementation and Capacity Building Opportunities. My name is Nicole Elenoff, and I am a Senior Manager on NASTAD's prevention team, and I'm joined by some incredible speakers who I will introduce shortly. This webinar will provide an overview of long-acting injectable PrEP, implementation strategies, cost and coverage considerations, as well as opportunities and resources for building capacity around injectable PrEP and jurisdictions. This webinar is scheduled to last for 75 minutes, including time for some questions and answers. And please keep your lines muted to ensure good sound quality throughout. I see that there are some folks introducing themselves in the chat function. Please keep going. Please keep doing so. It's really great to see how many folks are visiting or logging in from all over the country and in Puerto Rico. So as I mentioned, we will engage in a question and answer period, and this will take place at the end of the webinar. And if you have questions throughout, please utilize the chat feature and we'll make sure that your question gets answered. This meeting will be recorded and this webinar will be made available to you. I would now like to welcome, I'm going to turn the microphone over to Maria E. Alvarez with the Centers for Disease Control and Prevention for some brief opening remarks.
Good morning, colleagues. Thank you, Nicole. Good day, partners. My name is Maria E. Alvarez, and on behalf of CDC's Division of HIV, Program Development and Implementation Branch, I am pleased to welcome you to today's webinar as the Capacity Building and Technical Assistance Lead. Thank you for joining us today. We really appreciate you taking the time out to attend. CDC and NASTAD are pleased to bring you today's webinar, Long-Acting Injectable PrEP is Here. This webinar will provide an overview of long-acting injectable PrEP, implementation strategies, and offer opportunities for capacity building around injectable PrEP in jurisdictions. Thank you to NASTAD's TA team for coordinating this important session, as well as to all the wonderful speakers that are presenting today. In closing, a quick reminder that the Division of HIV Prevention remains committed to our ongoing partnerships, the provision of technical assistance services, and the implementation of the status-neutral approach to prevent and treat syndemic infections. Again, thank you to all the participants on the call, and also for all your local implementation efforts to support the Ending the HIV Epidemic initiative. Today's webinar clearly supports the prevent pillar. And as we have often heard, an ounce of prevention is worth a pound of cure. With that in mind, please enjoy the webinar. If there are any questions for CDC, please submit them to the PS20-2010@cdc.gov mailbox. Back to you, Nicole, and thank you for your TA leadership on this content area. Nicole?
Thank you so much, Maria. It's always great to have you join us for these webinars and being such a great partner. All right, next slide. Oh, awesome. So I'm not going to go through all of the amazing NASTAD PrEP team members, but wanted to share, it takes a village, and NASTAD has a multidisciplinary PrEP team that stems across many different programs here at NASTAD, including our health systems integration team, healthcare access, our prevention team, our Policy and Legislative Affairs team, and wanted to briefly bring up some of my other team members into this conversation. All right, next slide. So our outline for today, we're going to start with an overview of long-acting injectables for PrEP. We're then going to discuss some implementation opportunities, followed by some cost and care coverage considerations, some capacity building opportunities. We'll briefly review some of the current long-acting injectable resources that are available and would love to hear some feedback from you all as well. And then we'll end with some Q&A. Next slide. So let's introduce our incredible speakers for today's webinar. Our first speaker today is Dr. Rupa Patel. Dr. Rupa Patel is an infectious diseases physician and is a research associate professor voluntary in the Division of Infectious Diseases at Washington University in St. Louis. She's the former director of the Midwest CDC HIV Prevention Capacity Building Center, and she has experience in developing non-traditional PrEP delivery models, which includes pharmacy-based care, teleprep, and incorporating at-home self-lab testing. Welcome, Rupa. Our next speaker will be Tim Horn. Tim Horn is the director of the Healthcare Access Team here at NASTAD. He oversees and supports all activities related to Ryan White HIV/AIDS Program, Part B, and AIDS Drugs Assistance Program, fondly known as ADAP, Technical Assistance, the National Ryan White HIV/AIDS Program, Part B, and ADAP Monitoring Project, and the ADAP Crisis Task Force. Tim also works closely with NASTAD's Health Systems Integration Team and Policy and Legislative Affairs Team on prescription drug pricing and coverage priorities, including 340B drug pricing program navigation and sustainability. Tim has been engaged in HIV treatment and prevention research and access advocacy since 1992. He holds a master's in science from the City University of New York and a bachelor's of arts from Hampshire College in Amherst, Massachusetts. Welcome, Tim. And then our last speaker this afternoon, or wherever you're logging in from, is Dr. Benjamin Tsoi. Dr. Benjamin Tsoi is the Director of HIV Prevention in the Bureau of Hepatitis, HIV, and Sexually Transmitted Infections at the New York City Health Department. He oversees HIV prevention initiatives and funded HIV prevention programs, such as those for HIV testing, PrEP, PEP, and immediate ART initiation. In addition, he has co-authored multiple manuscripts on HIV testing and provides technical assistance to community-based organizations and other health departments on HIV testing and other prevention topics. His training is in family medicine. Welcome, Dr. Tsoi. Really excited to hear from this robust panel of speakers. And with that, I will turn it over to Dr. Rupa Patel.
Thank you, Nicole. Thank you for everyone for attending. Just going to share my screen. Share. Excellent. So I'm going to go ahead and follow those wonderful introductions and precede the next speaker, who's going to give you a in-depth view in a certain jurisdiction. I'm going to really just cover the injectable option right now, the science behind it, and then move into some of the overarching kind of themes of successes and challenges regarding implementation, and some broad categories so that everyone in the audience can start thinking about implementing it in their own structure, whether it's a health department, city, county, state, whether it's a federally qualified health center, whether it's a community-based organization, and then we can dive into the deep questions that you may have during the Q&A. And so I'm just going to do a broad overview, because as we're talking about injectables, we absolutely can't forget about the current options today, because one seed I want to plant already is that as clients and PrEP users engage with the injectables over time, their ability to want the injection or take the injection or their risk may change in a way that you'll want to always provide the menu of options along each step of the way for all your clients. So I want to go over today's oral. We have today's daily oral PrEP with FTC and TDF and FTC and TAF, the generic, the Truvada, the Descovy tablets we have here today. One key information piece that you should know about of the current options today is that when the creatinine clearance is above 30 but below 60, there is one option available, and that's the tenofovir alafenamide that's FDA approved. And then we have another FDA option after the two oral options, daily oral options. We have Aptitudes. We have a non-FDA approved but widely accepted use of 211 that has been endorsed by several health departments. So please see what your health department is recommending. And we have the mention of 211 in the CDC guidelines. Before we go on to other things, I do want to remind you, now we have so many options for PrEP today, including the injection. So let's make sure you know, first and foremost, these wonderful hotlines that CDC has created with partnership with other organizations, so that you can call and talk about how to discuss the menu of options, how to help transition clients through their journey in PrEP for the year, from injection to oral, back to injection, or start and stop based on the client's needs and their risk at that time. And as we're implementing, I just want to go ahead and lay out a few frameworks. The first framework is we've got that status neutral care continuum, and we talk about the left-hand side. When someone is HIV negative, it is really, really important to be on the same page as multiple persons and colleagues and organizations and agencies about how we look at that continuum. After testing, we educate the client about all their options for PrEP today, and if they're at risk, and the need or the benefit of a biomedical option today. Again, we have daily oral, we have an injectable, and we have an on-demand option. After that individual is made aware of, we will link them to a provider. We'll get the appropriate testing. We'll get a prescription. Please don't forget that individuals then need help getting that prescription at the pharmacy. And then they go ahead and they will have follow-up visits based on the CDC guidance, as I'll lay out, between 1 and 3 months and 1 and 2 months of guidance where they'll have follow-up. And so when you start looking at how we implement the injectable and what are the categories that lay for challenges, I want to first talk about the awareness component and having that shared decision-making in the office with the clinician and the client about all the menu of options. And yes, we really need some good infographics on the options today, because all the different options are confusing people and all the side effects, etc. And then once you've made aware from someone, we've got the linkage to care and the prescription. We definitely need all organizations will have to start setting up work groups and robust billing experts to see what the options are there today based on the multiple insurances we have in the United States. And then after we initiate PrEP, so linkage and prescription is considered, moving towards initiation. So prescription, starting something. We want to then start following people up, and that is the retention or the persistence piece. So to highlight, you have awareness, you've got linkage to care, to a center that prescribes injectables or daily oral PrEP that's culturally competent, provides that safe space. And then you've got the entire initiation, so prescription and getting the pharmacy to fill it. And then you've got follow-up. And I want us to always think about those recurring themes. And when you talk about these steps, remember, when you place this in an organization, there's 3 layers. There's the patient level, the provider and staff level, and then there's really the organizational structural level with billing and leadership and organizational adoption. And I'll go over that as we move forward. So I want to transition into the 2021 guidelines. Table 1A very clearly laid out in December 2021, the updated guidance laid out the oral, daily oral PrEP options with Truvada or generic or Descovy, FTC, TAF, or and TDF. I'm not going to spend a lot of time on table 1A because I'm going to move to table 1B. This is very important, page 16 of 108 in the guidelines. This really starts laying out the injectable for us and how to identify eligibility. And then our clinical eligibility, as a reminder, that HIV test, antigen antibody 1 week before, and then no signs of acute HIV, no contraindications to medications. Remember, this year's CDC guidance, or the updated version, does have a different testing algorithm. If you're PrEP naive, if you're PrEP exposed, please be aware there's the viral load testing if you're PrEP exposed, in addition to the antigen and antibody testing. I will not cover that portion of the guidelines today, as I'll focus on the injectable today. Then you'll go ahead and order the injection, cabotegravir, 600 milligrams. It is a 3 ml intramuscular injection. Compare that to syphilis injections with bicillin, which are about 4 milliliters, 1 injection, and those are 2 injections a piece in each buttock. This is a 3 milliliter one-time intramuscular injection in a ventrogluteal location that you'll inject. I want to highlight it is only advised as a gluteal intramuscular injection. That is ventrogluteal. It is not the arm and it is not the thigh. And so you'll give 1 dose, and then 1 month later or 4 weeks later, you'll give another dose. And then every 8 weeks thereafter, you'll give another dose. And so at each visit, you will obtain in the follow-up care an HIV test, antigen and antibody, plus an HIV RNA viral load test, quantitative or qualitative. Please check on that. There's difference in prices for qualitative and quantitative. Most of the centers are connected to large labs such as Quest and LabCorp, etc. You may already have that in your ordering menu. And then, of course, we CDC, as all providers, are fostering clean needle exchange, access and referral to support services, bacterial STI testing, pregnancy testing as appropriate, and other testing as you have your conversations with your clients. The CDC guidelines of Table 7, again, these guidelines have been really well laid out in terms of graphics. I'm highlighting the graphics that you may actually cut and paste and put in your offices, or use in provider trainings, or use to sensitize your staff. And so Table 7 really walks you through it, what you can do at the initiation visit, 1 month, and then every other injection visit, which is considered every 2 months. And they lay it out as the 2-month injection visit after the initiation, and then the 4-month, etc. And then I want to refer to the workflow that you'll start to consider on a clinical level. As I've described, after you'll have the history taking for eligibility, the clinical eligibility by asking about acute HIV in labs, you'll go ahead and initiate the injection with the first 2 injections. I want to highlight the oral cabotegravir as an option is an optional oral lead-in. There's guidance by the CDC on that. But I want to go into the injections because I think one of the anxieties that comes up with this is that if someone doesn't show up, if someone misses an injection, and I want to explain that to you. I took the guidance right from the FDA because I think it's important to talk about some of the days. There's a plus or minus 7-day window for each injection. So that 7 days before, 7 days after, you can decide what is good for your client. Many times I, as a provider, have been, doing 7 days before the actual injection date. so that in case they miss it, then they fall right on the injection date, that exact 8 weeks later. And then in case they miss that, they had the 7 days after that. But you need to know that there's a 7 day before, 7 day after, or total 14-day window. And the way the guidance by the CDC and the FDA have looked at this is if this planned or unplanned. And I'm going to take you to a table. The bottom line is you have planned visits and unplanned visits, and you have some window room of when you can go ahead and give the injection. And then table 3 also describes if you're in the initial injection phase, since the client has to come for injection 1 and then 1 month later injection 2, the table goes ahead and talks about if you're in that injection initiation phase, do you repeat initiation? Or on the bottom of the slide, if you're in the maintenance phase of the injection after you've delivered the 2 loading doses of injection 1 and 2, 1 month apart, then what do I do about delivering the injection every 2 months? I don't want anyone to memorize this. That's the one important thing about the challenges and the successes of implementing at the provider level. Don't get overwhelmed. Cut and paste these, put this in the room, and then eventually you'll memorize some of these windows as you're prescribing. And as I'll talk about later, when you start to maybe devise injection clinics, you'll have your training, and then you'll go ahead and say, what are these tables I want to keep in the process of the room? Now, I'm going to spend a few slides very briefly. I'm going to run through some of the science because this will come over and over. And I know there's been several talks on this, but I do want to remind a few things, key things about the science as we're talking about it as part of the CDC, CIBA and other HRSA and other kind of capacity workforce about HIV prevention and capacity building. One is when we talk about the injection on the top of this, I've taken this exactly from the articles that have come out. A few things to consider is when we did look at these, when we did look at the studies, very importantly, let's talk about who was excluded. You have to remember those that had active IV drug use and history of liver disease and had surgical implants in the buttocks. Those individuals were excluded. I think that's just something you need to know about the studies. People included were above the age 18 and sexual risk. However, you do need to know under all the guidance, we do offer this injection for IV drug users. And we have great caution when someone starts to say they have implants, etc. And you have to have a deep discussion about any surgeries in the buttock area, including skin contouring and the use of fat to shape the buttocks and how the depth of the needle will go in, etc. And I think these are the situations you can call the CDC hotline and ask about the one-on-one cases. So not to get overwhelmed as you're starting implementation, but know where are some things that you'd want to pause and ask a hotline or ask a provider such as myself. Everyone will get a couple of providers' names and emails by NASTAD, so you have some peers to talk to when prescribing. The top of the slide, just briefly, I want to highlight that the injection was compared directly to not a placebo group, but a group that was getting daily oral PrEP, and that's how we go ahead and we compare when we're talking about numbers. And in terms of just the study and looking at the percentages, I want to remind everyone over 80% of the study was among men who have sex with men, around 13% transgender women who have sex with men. And in terms of age, the ages were along what we see in the epidemic. The bulk of the individuals were young adults, 18 to 29. And when we look at the United States, when we look at ethnicity and race, we had 18% Latinx, and we have Black participants, about 50%. And when we start looking at the graphs, I don't want to overwhelm anyone. I want to just highlight a few things. When we look at the efficacy, or in terms of this double-blinded randomized control trial, and we start to look at how did cabotegravir as a long-acting injection do for the primary goal of preventing HIV compared, this is the dotted line on the top of this slide, the orange line compared to the blue line, we can see very early on, cabotegravir kept new infections very low. That's why it's a flat line in this Kaplan-Meier curve. And you can see there was rising infections in the blue line, the TDF-FTC. And you can see that very early on, it was shown that the cabotegravir injection was very effective. And it's not only by the sheer numbers of infection, but actually how early you can see these lines move. That was very impressive. And I'm going to take you to the bottom of the slide. So overall, they show that, you know, this was well over overall 66%, 67% effective when they released the first New England Journal article defining the efficacy. And then on the left-hand side, you can see all these bars. I just want to take you, what they showed very clearly is when you started looking at subgroups of transgender women, age less than 30, race of Black in the United States, and then the United States cohort, you could still see that it was well over 66% effective, you know, by the end of the blinded portion of this study. So it just gives you confidence that a study done all over the world, when you started looking at the numbers to our epidemic as practitioners in the United States of America today, in the EHE counties, the data was very strong. What I showed you was HPTN-083. In just 30 seconds, I'm going to outline the sister of that study, which was done in cisgender women. And again, it was the same double-blinded placebo-controlled study. I want to highlight the exclusion criteria. Women who were pregnant and breastfeeding were not included, or those with liver disease. And again, you had to be sexually active in terms of your risk for HIV. And again, this is another way of looking how the study was done, where they did step one, some oral pills for 5 weeks. Then they gave you this injection every day, a dummy injection plus oral PrEP, or the real injection with the actual cabotegravir with a dummy pill. And then they went ahead, and then for the latter year, they gave you a pill of TDF, step 3. And so some really renowned, important things to talk about is, you know, the study was done in sub-Saharan Africa, but in terms of the age, we do have many of the women were in their 20s. We have Black African, we're over 90%. And in terms of risk, you know, I think it's important on the right-hand side just to see that the risk was defined as greater than 2 sex partners. Each of them had around 50%. So that was the risk. There was transactional sex of around 40%. And then we had, you know, unknown partner status about 1/3. And we had a BMI of above 30 at about 30%. That's relevant in our clinic today. About 30% or 40% of the clients I'm serving today and I'm giving the injection do have a BMI above 30. And so this is reassuring that we know that the PK levels work, and the, you know, the dosing is great. And again, what was very resilient in both of these studies is, again, the blue line on the bottom is cabotegravir, and the top line is the oral daily PrEP. And what you can see is, again, very early on, those lines start to, you know, show themselves in terms of the prevention of infection. And that's really telling on top of the overall numbers. Just recently at AIS in Montreal, the group HPTN-08 did show that in the, you know, when they finished the study in terms of blinding and unblinding, so over 4 years, they showed that they really at the end, from the New England Journal of Medicine article to now, or the Lancet article to now, they really did maintain over 88% efficacy in the reduction of HIV with cabotegravir when compared to TDF-FTC, or you had only 6 injections in the cabotegravir arm and 56 injections in the tenofovir oral PrEP arm. And then other things that came out of this study, because I wanted to lay the foundation of tomorrow's, you know, several years from now, 2 important things came out. One, as activists and leaders in the HIV prevention space and providers, we do need to take the lessons learned of treatment. So rilpivirine, with cabotegravir is used, called Cabenuva, is used for HIV treatment. And we're looking at some of the data from that to be able to say, how do we better inject for HIV negative clients, and how has implementation gone? Well, one of the biomedical studies I wanted to highlight here was that they actually started looking at alternative site injection, and they started looking at lateral thigh. And this is kind of the new era. We're taking an FDA approved drug. We're looking at it in different ways through these studies. And I just wanted to let you to say, stay tuned, because we're providing evidence for self-injection and partner injection and lay injection as we start moving as a community, as CDC guidance, FDA approval, et cetera. It'll be way down the road, but we're starting to help get the evidence that we need. And as we start to do research or implementation science research, we need to start understanding what we can do as a group, and what do our clients want? Are the clients going to be open to provider injection, lay injection, partner injection, self-injection, etc.? Again, I'm just laying down our implementation efforts and our thought processes for several years down the road. So what we do today in the clinic will affect some of these concepts later and how we implement them. And then the other great kind of groundbreaking stuff that's going on is they're taking that same FDA approved drug, that 600 milligrams of cabotegravir, and they're looking at it in a smaller concentration. So that's less than 3 milliliters, it's not so large of a volume. And they're looking at it in a smaller volume in the same thigh, buttock, and also subcutaneous abdomen. So subcutaneous abdomen for everyone in the group is what we look at as insulin injections. And again, this is very important for us to just know about these things, because these may be our future products. And so going into 30 seconds of future products, again, what we do in the clinic today to help tomorrow's products is really vital. As you're looking at this cabotegravir, again, an FDA-approved product of 600 milligrams for a long-acting injection every 2 months, but the same molecule is being looked at a micropatch, and it's being looked at in an implant. And then, as you know, that in general, when we look at future PrEP products, we're looking at rings, implants, injectables, and antibodies as broad things. And when you look at what's happening, you're taking every single medication we have, and you're putting it in every type of different formulation. So AVAC has a wonderful pipeline graphic, and I'm not going to spend any more time on it. I just wanted you to be aware that this is where the future information is housed, and you can see that there's injection patches, etc. And it breaks it down of what are we doing in animals and what are we doing in phase 3. And what's important to just drop the word, if you already haven't heard it, is multi-purpose technology. An example is the yellow on the bottom is HIV positive, HIV and contraception. And so you've got some phase 1 and phase 2 things going on. And then you've got a 6-month injection, lenacapavir, in purpose 1 and 2, which is also a subcutaneous abdomen injection. So we've got a lot of injections going on. And so I'm going to spend the next 1 to 2 minutes talking about our lessons learned in our injectable implementation before we do a deep dive into the New York cohort. The main thing is, let's take a step back and see what happened with the rollout of the FDA-approved HIV positive treatment, Cabenuva. A lot of the clinics have a bitter taste in their mouth, so you want to check in and see, as activists and implementation specialists and part of the HIV prevention workforce, how did your clinic do with rolling out the injection for Cabenuva? Did you have any problems? Did you have any resource issues? And a lot of people will tell you there was a lot of fatigue when setting up those work groups and trying to get that injection clinic running and, going ahead and figure something out. One important point to the audience is that the injection is prescribed, and then the injection is received at the pharmacy, and then that pharmacy cannot deliver that injection to your client's hands. It has to go to the provider or to the clinic. And so the clinic must have somebody to receive the injection and document it and do all those logistics. So while we look at the patient level of can they receive the injection, and the provider level, if they're comfortable with giving the injection, we have to look at the organizational level, all the logistics and structure, that did they have the ability to get the injection, document it, time it with the person's visit, and then did they have time to inject in an injection clinic. And remember, when you're running a clinic of 5,000 people or 100 people, the flow of injections from pharmacy to the client's scheduled visit is very cumbersome. And please think about that. Also, there's something very different. It's the whole medical benefit and the pharmacy benefit. You will need a robust billing team to understand how to buy and bill. That means purchase the medicine and then get reimbursed later. Reimbursement from multiple insurances means multiple paperwork. It's a delay in getting the medication. That means you may actually miss your window period if you don't order the medication in time. And so then I'm just wrapping up. And then when we think about that with LAI considerations, we do that at the same time. We look at client level, provider level, organizational level, and the main implementation considerations are your work groups and your sub work groups. That will be your injection delivery, your follow-up for the missed appointments, the billing, and then you'll need all the training around how the injections work. So these are some of the key points. And so when we start thinking about some of the limitations as we scale up, we'll need to think about how are the injections folding into task shifting? How can we remove injections only from providers? Can we couple this with televisits? Can we then implement this in the pharmacies and, kind of the street medicine and all the other things we've been doing with PrEP and kind of the coverage we need? And so in conclusion, you've got the data that, prescribe the injectables, and then you've rolled into some implementation challenges. And one way to look at that is those 3 levels: provider, client level, and kind of the structural issue of the logistics and the billing and the medical acquisition and the documentation. So without further ado, I'm going to go ahead and turn it over to my colleagues from New York.
Thank you so much, Rupa. We're actually going to go to Tim next to talk about some of those coverage and cost considerations that you helped brief us on. So thank you.
Great. Thank you, Nicole. And thank you, Dr. Patel, for that brilliant overview of the workflow considerations, implementation considerations, and the scientific considerations. And so before we hear from Dr. Tsoi, Nicole and I really wanted to provide a nuts and bolts review of access and coverage considerations with which all PrEP programs will need to be familiar and to factor into long-acting injectable implementation plans. So I'd like to begin with sort of a high-level overview of Aptitudes, access and coverage considerations, some of which we'll be reviewing with a bit more detail in this segment, and some of which Dr. Patel did touch upon during her presentation. So first, the list price or the wholesale acquisition cost for Aptitude is currently $3,700 per 3 ml kit. And this translates into an annual cost of approximately $22,200. However, the estimated cost for the first year of Aptitude is around $25,900, which takes into account a total of 7 doses, including the 2 initiation doses that Dr. Patel referenced in her remarks. Now, of note, these costs are the actual costs for the actual drug product. They do not include office visit and administration costs associated with Aptitude as a provider administered drug. As for oral Vocabria, oral cabotegravir, if the optional oral dose is recommended, this is available free of charge from the manufacturer, and Vocabria is not being made commercially available through community retail pharmacies. Second, and again, because it is a drug that requires administration by a licensed healthcare provider, Aptitude is not available through traditional retail pharmacies, but rather through a controlled distribution system set up by the manufacturer involving specialty distributors and specialty pharmacies. And it is through specialty distributors and pharmacies that Aptitude can be procured by healthcare providers through buy and bill, white bagging, or clear bagging mechanisms, which we'll be reviewing in just a moment. And third, as a provider-administered drug, insurers are most likely to cover Aptitude as a medical benefit, as opposed to a pharmacy benefit, much like they would most oral medications. However, some insurers may cover it as a pharmacy benefit or as both a medical and a pharmacy benefit. So in terms of how buy and bill works, providers effectively submit orders for drugs or biologics they plan to administer in their clinics or practices to a specialty distributor, with the products then shipped to, paid for, and stored by the provider. So effectively, the provider actually owns the medication until it is administered. Now, following administration of the product to the client, the provider then bills the client's public or private insurance provider for the medication, administration, and any relevant office visit costs. Now, the provider also bills the client or a relevant copay assistance program for any copayment or coinsurance requirements. Now, note that clearbagging is a variation on this theme in which a health system's internal specialty pharmacy maintains inventory of the drug or biologic, processes the claim when a prescription is received from a healthcare provider, and then delivers the medication in time for the patient's appointment. So, with white bagging, the provider submits prescriptions for Aptitude to a specialty pharmacy within the specialty pharmacy network. Now, a list of participating pharmacies can be found on the ViiV Connect website. Now, the specialty pharmacy processes the claim, including charging the client's insurer for the cost of the medication and the patient, or the patient's manufacturer, or the manufacturer's copay assistance program for any cost sharing, and then ships the product to the provider. Now, once the medication is received by the provider, it can only be administered to the patient for whom the drug was prescribed, and any administration or office visit charges may be billed separately. Now, in terms of insurance coverage considerations, let's first talk about commercial payers, including Affordable Care Act marketplace plans and off-marketplace plans. Now, most commercial insurance carriers are expected to cover Aptitude as a medical benefit versus a pharmacy benefit or standard prescription drug benefit. In turn, Aptitude may not appear on the plan's traditional prescription drug formulary, but instead on a separate medical benefit drug formulary or list. In fact, many plans may still be making their coverage determinations for Aptitude. This can take around 6 months to a year following the approval, including whether to implement utilization management, such as prior authorization, particularly if there is a coverage preference for lower cost generic oral PrEP. Now, if covered as a medical benefit, the client may be responsible for paying 20% of the total cost after the plan's deductible has been met. And if covered as a pharmacy benefit, specialty drug tiering, including the possibility of a percentage-based cost-sharing requirement, and separate office visit and administration out-of-pocket costs may apply. Now, some plans may apply the 2019 U.S. Preventive Services Task Force Grade A recommendation for PrEP to Aptitude, which could potentially translate into a no-cost sharing requirement. Now, for plans that haven't or don't plan to waive cost sharing for Aptitude in alignment with the current USPSTF recommendation, an anticipated update to the PrEP recommendation is now under development and may ultimately expand the $0 cost sharing requirement for this product. Now, it's also important to note that the manufacturer has a copay assistance program for Aptitude, covering up to $7,850 in cost-sharing expenditures per year, including relevant administration and office visit costs. And here, I would just recommend you visiting the ViiV Connect, ViiVConnect.com to learn more. So now, with respect to Medicaid, most Medicaid programs are expected to cover Aptitude, though coverage requirements, payment methods, and any possible utilization management, again, things like prior authorization, may vary from state to state. Now, cost sharing for drugs covered by Medicaid, including those requiring provider administration, are typically nominal. It is important to note, however, that the manufacturer's copay assistance program cannot be used for Medicaid cost sharing. Now, for Medicare clients, Aptitude is expected to be covered under Part B as in boy as a medical benefit versus the Part D pharmacy benefit. Now, under Medicare Part B, the beneficiary may be responsible for, again, up to 20% of the medication cost after the deductible requirement has been met. However, a supplemental insurance coverage such as Medigap, Medicaid dual eligibility, or enrollment in the qualified Medicare beneficiary program may defray cost-sharing requirements associated with the administration of Aptitude. Now, some Medicare Advantage plans that include prescription drug coverage may opt to cover it as a pharmacy benefit, which, unlike Medicare Part B, has annual caps on out-of-pocket spending for beneficiaries. Now, as with Medicaid, the manufacturer's copay assistance program cannot be used to defray Medicare Part B out-of-pocket costs associated with Medicare, though there may be an opportunity to defray costs for Medicare beneficiaries who meet income requirements under the manufacturer's patient assistance program, which we'll be talking about in just a minute. Now, for the sake of time, I am not going to go into reviewing everything that you see here, but most payers require specific coding in claims for provider-administered drugs. These include the Healthcare Common Procedural Coding System J-codes, National Drug Codes, International Classification on Diseases codes, and current procedural terminology codes. Now, the relevant codes for Aptitude are listed here and may be a useful reference and will be available via the slides to be distributed following the conclusion of this webinar. Now, lastly, for people vulnerable to HIV without insurance coverage or coverage limitations, ViiV Healthcare is providing access to Aptitude at no cost to individuals who meet all of the criteria on the left side of the screen and one criterion on the right side of the screen. So in terms of eligibility, individuals must reside in one of the 50 states, the District of Columbia, or Puerto Rico, have a household income that is below 500% of the federal poverty level. So for example, income that does not exceed $91,500 in a household of two in 2022 and cannot be eligible for Medicaid. Additionally, they cannot have prescription drug coverage or have private insurance plans limited to generic only coverage, outpatient use only, or therapeutic class exclusions. Now, a third criterion pertains to clients who have Medicare Part B, Medicare Part D, or Medicare Advantage plans. Now, for those beneficiaries who have spent at least $600 or more on out-of-pocket prescription expenses during the current calendar year, they may be eligible to receive Aptitude at zero cost through the Patient Assistance Program. So I am going to end with that, and we look forward to your questions and hearing about your own access and coverage successes and challenges during the Q&A. And with that, I am going to turn it over to Dr. Tsoi.
Good afternoon. Thank you for having me share the New York City Health Department's efforts to build capacity for injectable PrEP. Next. In thinking about this presentation, I found it helpful to look back at the implementation of oral PrEP and see what we can learn from it. And earlier in this presentation, Dr. Patel talked about the different options available for PrEP, but back in 2012, the FDA only approved TDF-FTC for PrEP. Next. In looking back at 2012, this slide shows data from a sexual health survey that we regularly conduct among sexually active gay and other men who have sex with men. And in anticipation of the FDA approval, we asked men who were surveyed about PrEP awareness and PrEP use. And what we found is back in 2012, when PrEP was approved, a small proportion, about 30% of the men surveyed reported knowing about PrEP, and then only a few providers were ready and willing to prescribe it. Next. So what we find in 2012 was that the demand greatly exceeded supply, where many providers were reluctant to accept referrals from patients outside of their network or their practice. And many providers voiced concerns that they were worried that PrEP referrals would really overwhelm the practice. And as a result, many consumers, clients were frustrated by the lack of PrEP options and also by the lack of providers who are able to offer PrEP. Next. Also, another situation that impacted the availability of providers to prescribe PrEP is a term that was later called the purview PrEP paradox. In this situation, providers who are most experienced and comfortable in prescribing HIV medication, such as HIV providers, they don't feel that they're in the best position to prescribe PrEP because most of their patients or all of their patients are persons who are living with HIV. However, primary care providers who may see many patients who test negative for HIV, they don't necessarily feel that they're in the best prescription position to prescribe PrEP because they feel that PrEP prescribing is too complicated. So we're in this awkward place where sort of like we really don't have not clear who are the appropriate providers to offer PrEP. Next slide. So let's sort of fast forward and see where are we today. This slide shows the rollout of oral PrEP in New York City, and it shows pharmacy data from Symphony Health and also from the New York State Medicaid data program, showing the number of individuals with filled PrEP prescriptions. And what we find is that for the data for New York City from 2014 to the present, or until 2020, we see a steady increase in terms of the number of PrEP prescription until 2020 when COVID hit. Next slide. And going back to the other slide that I showed earlier from our sexual health survey, what we found is sort of corroborating information that we amongst sexually active gay and other men who have sex with men, we see an increase in PrEP awareness to the 90s in New York City. And then we also see associated increase in PrEP usage to the 30s. Next. Even though it seems like we're doing well and prescriptions are increasing, we are seeing there are disparities in use. This slide shows the pharmacy data, but now displayed by race. And what we see is that there's more PrEP use amongst persons who are white, which is shown in green, than persons who are Black and Latino. And in New York City, people who are Black and Latino account for the majority who are living with HIV. Next slide. And when we look at PrEP use by sex, what we find here is that, again, more PrEP use amongst males than amongst females. In New York City, for every one case or one diagnosis of HIV amongst women, there are 4 cases amongst men. And while I don't know what's the ideal uptake of PrEP amongst women, that is certainly not the ratio that we see here. What we find here is that for every 1 woman on PrEP, there are 10 men on PrEP. So we certainly want to see the number of PrEP prescriptions among women to increase. Next slide. In addition to sort of like availability, I think that messaging really also affects PrEP intake. This is just a slide from CDC from 2017, providing guidance on who has an indication for PrEP. Next. And what I want to highlight is that the wording is PrEP is for people at substantial risk of acquiring HIV infection. Next slide. And this risk-based messaging has resulted in stigma and negative perceptions of people who are on PrEP. People on PrEP are perceived as promiscuous, and a term that has been used for people on PrEP is Truvada whore. So it's really, it could really impact sort of like uptake and adherence. And the next slide shows a study from researchers from Northwestern who presented the conference on retroviruses and opportunistic infections. And what they reported is that young people who hold stigmatizing attitudes regarding the use of Truvada as PrEP are less likely to take the HIV prevention pill. And if they're on it, they're less likely to adhere to a daily regimen. So In all those things, then sort of like how we talk about PrEP is just as important as talking about PrEP at all. Next. So kind of tying things up, I'm sharing some of my thoughts in terms of considerations then on how on implementation of injectable PrEP. One of the things that we want to do is really promote and support providers. Think about the supply side to meet the demands of consumers, which means that we need to increase the number of providers who can prescribe PrEP, including injectable PrEP. Next. We also want to increase PrEP awareness and usage amongst persons who are Black and Latino, and also amongst women. Next. And we also want to support consumers in understanding the different PrEP options. And as Dr. Patel mentioned, there are many available. And then we will also, in our support of clients, we want to help them in deciding which options is best for their needs. Next. And lastly, we want to promote and offer PrEP as a prevention option in a sex positive and affirming manner, really addressing sort of like the stigma that I've mentioned about related to PrEP. Next. So in New York City, we have drafted an injectable PrEP work plan. Next. And it consists of 2 phases. Phase 1, learning and identification, consists of learning about PrEP, identifying community needs, and advising existing resources. And then phase 2, develop and disseminate, is developing new materials, engaging in activities that support implementation, and also revising materials. And this is an iterative process. Next. So in terms of identifying community needs, next. Next. The New York City Health Department conducted, seems like my titles for my slides are not showing up. Well, anyways, the New York City Health Department conducted online needs assessment among staff of partner clinical and non-clinical agencies of our large community engagement initiative, New York Knows. Next. We did a needs assessment between March 14th and April 4th of 2020, and we sent it to our over 2,000 individuals who are part of our initiative. Next. And 89 people completed the survey, and of those who responded, 43% worked in the community health center or a clinic, and 38% worked at a community-based organization. Next slide. What we found was that more than a third of our respondents said that they have started beginning to discuss implementation of injectable PrEP at their agency, which also means that about 2/3 of them have not. Next. And most of our respondents were either slightly prepared or not prepared at all to discuss injectable PrEP with their patients. Next. And they told us to make injectable PrEP available at their agency, they would need client education materials, provider education materials, and also standard operating procedures for agency staff to implement for the next 3 months. Next slide. And the top 3 topics that respondents wanted to learn more about were costs and insurance coverage. And Tim kind of introduced us to like the complexity that is really involved in terms of that, eligibility requirements, and also side effects. Next. And of those respondents who saw patients, they reported that half of their clients were interested in injectable PrEP. And they also said that when they had clients who were not interested in injectable PrEP, the top 3 reasons were concerns about side effects, costs, and also not knowing enough about cabotegravir. Next slide. And then finally, the most reported challenges that they were for implementing injectable PrEP were, next slide, insurance and prior authorization process, billing and reimbursement, and then also talking about the cabotegravir tail, which is the time period after injection has stopped and the drugs are slowly diminishing in the person's body, and then needing to talk to the patient about other preventive needs to protect them against HIV infection. Next slide. So that was sort of like what we did in terms of assessing community needs. Other things that we did is revising resources. Next slide. So one of those is that we updated the health department website on PrEP for our providers. Next. In addition, the New York State Health, New York State Department of Health AIDS Institute also manages a clinical program, clinical guidelines program, and in next slide. In May of 2022, they updated their guidance on PrEP, which included also a guidance on injectable PrEP. Next slide. In addition, we started developing some new materials next. So in August of this year, we released a Dear Colleague letter to prescribers, telling them about CDC's updated guidance on PrEP and also letting them know about the availability of injectable PrEP, and then also turning them to resources available to help them with the implementation. Next. And then in terms of the biggest thing that we're working on right now is really those activities that would support implementation. Next slide. And thinking back to my slide on considerations for implementation, one of those is really to build increase availability and supply for injectable PrEP. And we've already heard that injectable PrEP requires more logistical support beyond just merely writing prescriptions. Next. So what we sought to do is to build a base of providers who can provide injectable PrEP. Next. So we partnered with the University of Rochester, which is a CDC-funded SIBA provider. Next. And we created a learning collaborative agencies that can prescribe and offer injectable PrEP. Next. And as part of their joining the learning collaborative, we asked that they commit to implementing injectable PrEP during the course of learning collaborative. Next. And because we know that a team is needed for the successful implementation of the program, we asked that each agency assemble an implementation team with people that we think are important for that. So that includes prescribers, someone who would be supporting the clients with education and navigation, a facility administrator who would support sort of purchase of medications and also creation of standard operating procedures, and also a pharmacist because it's so much sort of like pharmacy based. Next slide. So lastly, talking about sort of next steps. Next. While we're in the midst of the learning collaborative, we hope that from the learning collaborative, we will gain information that will help inform some of the future activities that we'll be doing. Next. This includes the creation of an implementation checklist and support materials to help prescribers in prescribing injectable PrEP. Also, the creation of patient education and social marketing material. And as I mentioned in sort of past considerations, we really want to promote a sexual health model for PrEP use. And we also want to promote awareness of options and choice for clients. Next. And then finally, we also want to support the community-based organizations that conduct outreach and navigation services to PrEP prescribers in the community. While we, and then lastly, it's like we're in the midst of this, of the learning collaborative, so that I hope that in the future we'll have more to share in terms of what we learn. Lastly, I just want to acknowledge the hard work from my colleagues at the health department and also our partners. Next. And thank you for allowing me to share our experience in New York City.
Thank you so much, Dr. Tsoi. That was a really great, really great framework of what you all are doing in New York City. Thank you so much. All right, so I know that we are coming up on the end of our webinar. If we can go to the next slide. I wanted to briefly touch on some current NASTAD long-acting injectable resources. And the first one is our frequently asked questions for implementation. Some of what was covered today is also included in this FAQ guide, which includes information on cost and coverage considerations, oral lead-in coverage, patient access, lab requirements, and more. And I put the link in the chat for where you can go to access that material. And some of what was discussed today is reinforced in this resource. Our next resource that NASTAD has developed is a long-acting injectable cabotegravir dosing infographic. This infographic lays out the initiation and continuation doses, as well as the supplemental labs. We are currently updating this resource to make it even more clear where folks get the labs, who's getting the labs, and at what point. And we will be releasing that updated infographic shortly. I would love to hear from folks what other resources they would find helpful if you wanted to put that in the chat. But I think we can move on to the next slide. So NASTAD does have a large amount of PrEP access resources. Many of them can be accessed on the NASTAD's PrEP access microsite, which is the same place that the long-acting injectable PrEP resource is located. And again, everyone will have access to these links. Next slide. So I know many of you put in some questions in the chat. So for now, would love to hear some questions from folks. The first one, and I think this is a great question for Dr. Patel, is why does it have to be gluteal? Why is the injection gluteal?
Hi, Nicole. Thank you for that question. You know, I think it's just the depth of the injection and the how they want it in the muscle and the PK levels. And it's just how one of the sites they looked at. But that's why you have more studies coming along to start looking at the levels of cabotegravir in the body when you start looking at a different muscle group like the thigh that doesn't have as much muscle or is not typically injected. And then you start looking at the abdomen. And it's also a large volume, 3 milliliters. I want to let the room know, everyone in the room, remember your vaccine, even gender affirming hormones, these are 1 milliliter or less. Your vaccines are, you know, half a milliliter or 1 milliliter, depending on what you're getting. This is 3 milliliters. So this is considered a larger volume. I don't want to stigmatize a volume and call it large volume, but it is generally a larger volume than what we're used to giving other than the syphilis injection. So that is also one reason why I believe the gluteal area was considered a very safe and standardized way to deliver this much volume.
Thank you so much. This question is for Tim. Tim, can you talk about those that have non-coverage? For folks, for the patient assistance programs for private insurers, for those that have non-coverage, does that include plans that require use of Truvada or generic or Descovy?
Okay, that's a great question, and thank you for that question, Todd. So that does apply to, you can in fact have insurance coverage and be eligible for the patient assistance program. However, those are for plans that do not offer any prescription coverage whatsoever, or in the case of that the plan only allows for generic medications across the board, across all different therapeutic classes. However, if there is a preference for a generic product within a therapeutic class, for example, in the ARV drug class, like for PrEP, for example, in which there is a preference, or if there's that the coverage is limited to generic, TDF, FTC, for example, for PrEP, but there isn't a coverage option for Aptitude or Descovy for that matter, then in that case, the patient assistance program generally would not be available, just because there is a selection or preference for the generic product, like within that particular class. But again, if it is a plan in which only generics are covered across all therapeutic classes, in that case, there is the potential for eligibility under the patient assistance program.
Thank you, Tim. And I know that there's been some robust conversation in the chat, so thank you for those that are participating in that. I have another question for Dr. Patel, and that is about some of the labs that are required for long-acting injectable PrEP. And kidney test, or the creatinine clearance, is not one of those labs. Can you talk a little bit more about that?
Yes, I do also always want to reference the CDC guidelines. In the December 2021 guidance, there has been wonderful graphics on the monitoring of labs, and they've separated monitoring and the work, you know, kind of the clinical flow based on oral PrEP and cabotegravir. And to confirm, there is no need for baseline or follow-up labs for kidney testing or creatinine clearance or creatinine, what we say, nor is there a need to check your liver function panel or your liver tests.
Thank you so much. And I'm putting in a link to the 2021 PrEP guidelines in the chat for everyone to reference when they get a chance. And I think, are there any other questions that folks have that might not have already been answered in the chat or answered verbally? So I'm seeing in the chat, the biggest limitation at Chase Brexton Health Services in regards to implementing the injectable shot seems to be accessibility. You have to order it and have the client come back after their appointment to get the shot. You will lose the client from that. Is there any plan to make or a way to make the injectable regularly available to pharmacies? Thanks, Madison. And we could open that to anyone.
I can comment on that. This is Rupa. I practice in Washington, D.C. We have developed a collaboration with our pharmacy to have these in stock. And in fact, I've had same day cabotegravir injections being able to be delivered because we do try to deliver same day PrEP. There's a couple of things. One is talk to your pharmacy, see if you can keep these in stock. Another thing that we've started to do is we're calling clients if we know that they're PrEP clients and we're switching from oral to the injection, and we've spoken about it before. We're seeing when they're coming, we've been calling them and saying, hey, are you ready for that injection? Should I write the prescription, run the insurance so we have that injection ready for you when you come? So that's another workflow that I can recommend as you're starting up, is to maybe for, you know, a few clients here and there, start calling early and getting everything ready so that you can get faster and faster and understand what the flow is. One reason to do that is because we're trying to just get patterns to understand certain insurances and times. And that's been helping our billing team learn more and more as we have more and more prescriptions. I can pass it on to Tim and Ben as well to comment.
Ben, I don't know if you have any comments.
I don't. This is something we're working on supporting, but I haven't found a solution yet.
Thank you so much, everyone. We can go to the next slide.
Cool.
So to close us out, I wanted to share, you know, if you ever have a question, please reach out to the PrEP team, and you can do that at prep@NASTAD. So this is to reach out to any of the NASTAD PrEP team folks. Let's say you have a follow-up question after this panel or this webinar, please reach out and we will make sure that your question is directed to where it needs to go. Additionally, please sign up for NASTAD's PrEP Access listserv. I put the link in the chat. This is an opportunity to learn more about future PrEP Access updates, releases of new materials, updated materials, and just opportunities to stay in touch with NASTAD and all the moving PrEP pieces going on. I want to thank all of you so much for participating in this webinar today and for all of your interest in getting long-acting injectable PrEP implemented in your communities. I want to say thank you, a big thank you to our incredible webinar speakers today. Thank you so much for sharing your wealth of knowledge with us. And again, these slides and recording will be made available to those that participated. Thank you so much. And I see one comment in the chat: for more materials in the injection flow, please include what happens for planned and unplanned injections if it's not already included. Thank you so much. Absolutely. And I hope you all have a great rest of your day. And thank you so much. Cheers.